My name is Allie Megan Williams. I just finished my doctorate in September of 2022. And as part of that, I did a quality improvement project in the heart failure clinic that I work in. Just a little bit of background, the heart failure clinic that I work in, I actually opened in July of 2020, so in the middle of the pandemic. And that has in and of itself presented its own set of challenges. But it's also allowed for us to do a whole lot of quality improvement work. And one of those big initiatives that we took on was trying to improve advanced care planning and goal setting for our patients. So the pharmacist, Taylor, and I, and our nurse, who is no longer with our clinic anymore, but we all three went and got certified in first steps for advanced care planning so that we could try to better serve our patient load. So this is our team. Going from left to right is Pam, our front desk staff, who helped with screening our patients initially. Then there's Dr. Heatherly. He came and joined our clinic in, I think it was June of 2021. And he is our system director as well for pulmonary hypertension and heart failure. Next, we have Anna Laura, who is our coordinator for heart failure services. So she does a lot of our accreditation and things like that within the hospital. In the blue is Kathleen, who was our nurse. She now works from home, but she was really instrumental in this project. And then Taylor, our pharmacist, is last in the black. So as a brief introduction, the national cost burden of heart failure treatment in 2012 was about 30.7 billion US dollars, and the cost of end-of-life care really increased in patients without advanced care planning documentation filed. These services can include things like ICU stays, ventilation, the use of vasopressors, lots of heroic life-saving efforts that what in some cases could be avoided if a patient truly would prefer more palliative measures. As a local problem, I conducted an initial survey, and what I found was that in the state of Kentucky, the leading cause of death in 2020 was heart failure, which is not surprising given the diet and habits of my native Kentucky family. Patients without advanced documentation, care planning on file within our clinic was at about 75% prior to implementation. And within that population of patients in the heart failure clinic, 100% of them had 3 or more comorbid chronic conditions that could be considered life-threatening. Available knowledge for my literature review, I found that support staff involvement increases likelihood of ACP documentation completion, and I found that to be true within this project, which we'll talk about later on. Multimorbidity, so these patients having so many chronic disease states, also increases the probability of high-intensity end-of-life care, such as those ICU stays that I was talking about, and even moving to an LTAC-type facility. Heart failure just is so detrimental to the population that it harms. Advanced care planning documentation completion can mitigate these end-of-life care costs by hopefully preventing any unwanted heroic measures being performed. And patient engagement is variable and can be influenced by the use of a shared decision-making tool, which is sort of the crux of this entire project. The rationale behind this was the use of patient-centered care to increase patients' discussion of goals of care. The framework that I used was shared decision-making, and the tools that I chose for this project were the Where I Stand scale, which is a 2-page survey that prompts a guided discussion about goals of care and end-of-life care with the patients. After that, I used the mean sure test to assess for decisional conflict. The aim of this was to increase the filing of advanced care planning documentation within our clinic to 50%. Our clinic, again, is an outpatient heart failure clinic, and the time frame established was 8 weeks using the Where I Stand scale and mean sure test. This clinic is in Louisville, Kentucky, and a lot of our patients that we serve come from either rural areas outside of the county itself or from the West End, and both are very, very, very underserved populations. There has been a couple of studies done showing that there's what's called the 9th Street divide in Louisville, where patients farther out from that have a reduced life expectancy of 10 years. So we try to target that population of people in order to try to make sure that they at least feel that they have some voice in their plan of care. Our clinic itself is predominantly white, 80% white. 68% of our patients are on Medicare, and 52% of our patients are male. We do have a handful of commercially insured patients, and maybe 1 or 2 self-pay patients. This project was conducted using 4 Plan, Do, Study, Act cycles, and biweekly tests of change were created based on the results of those 2-week periods. The shared decision-making and decisional conflict assessment tools were utilized in all 4 of these sessions. So initially, my core intervention was just the ACP screening itself. So I had created a Google form, and this was used to screen the patient's charts beforehand to see if they met criteria for the shared decision-making tool. And that was determined by whether or not they had ACP documents on file. So if they met the criteria, then we would implement ACP screening. In PDSA 2, we discovered that our front desk staff wasn't really efficiently able to handle all of the screening because we only have 1 person at the front desk, but we have 2 people who manage rooming the patients. So they're going through the demographics